I want you to imagine a scenario that has probably happened to you like dozens of times. You're just walking barefoot on a wooden deck and you get a splinter.
Oh, yeah.
Or maybe you spend, a little too long at the beach and get a sunburn, or you just step off a curb wrong and twist your ankle.
Right.
We all know the immediate aftermath of that. The skin gets red, it swells up, it radiates heat. And I mean, of course, it hurts.
It does. And it's a sequence of events so mundane, like so baked into the human experience, that we rarely actually stop to consider the sheer scale of the biology unfolding right there in our tissue.
Yeah.
Because it is a massive, highly coordinated emergency response program.
Right, and we focus on the symptoms because, well, that's what we feel. But for this deep dive, our mission is to really look past those everyday symptoms. We are going to explore acute inflammation. We want to look under the skin and uncover the microscopic, incredibly precise choreography the body runs as its absolute first response to injury. So, okay, let's unpack this. What exactly are we talking about when we say acute inflammation in, a modern medical sense?
Well, we can define it as the immediate, short-term, stereotyped response of vascularized living tissue to injury.
Okay, stereotyped.
Yeah, meaning it basically runs the same program every time.
Yeah.
And the short-term part is key here. We are talking about a process that kicks off in a matter of literal minutes or hours and typically resolves within a few days.
Right.
Its entire goal is essentially this search, rescue, and containment mission. It exists to deliver plasma proteins and spectralized white blood cells, mainly neutrophils, from your bloodstream directly into the damaged tissue to destroy the threat, wall off the area, and just set the stage for repair.
And it's fascinating because that definition sounds so tidy, so purely scientific today. But the way humanity actually arrived at that understanding is honestly a wild ride.
Oh, absolutely.
Because for thousands of years, we only understood inflammation by what we could feel, not by what the body was actually doing.
Yeah, for roughly 1,800 years, we relied on an entirely phenomenological definition, which is just a fancy way of saying it was a description of symptoms with absolutely zero mechanism attached.
Wow. Just symptoms.
Just symptoms. The
Yeah.
oldest surviving description of those symptoms dates all the way back to around 30 AD, and it was recorded by a Roman encyclopedist named Aulus Cornelius Celsus.
Which is crazy because he wasn't even a physician.
No, not at all.
He was just this very thorough writer compiling all the existing Greek and Roman medical knowledge of the time into a massive text.
He was a brilliant note-taker, really. And in those notes, Celsus laid out the 4 cardinal signs of inflammation that are literally still taught today.
Wait, really? Still taught?
Still taught.
Yeah.
Rubor, which is redness. Tumor, which is swelling. Calor, meaning heat. And dolor, meaning pain.
4 Latin words that survived untouched for nearly 2 millennia. Like, you can walk into a first-year medical school lecture right now, and they are still teaching rubor, tumor, calor, dolor.
Yeah, they are.
Though I know a 5th sign was eventually added, right? Functio laesa, or loss of function.
Right.
And medical historians still sort of argue about who actually formalized that one. Like, some say it was the ancient physician Galen in the 2nd century, and others say it wasn't really locked in until the 19th century by the famous German pathologist Rudolf Virchow.
Which, perfectly illustrates how medical knowledge is assembled. Even these classic foundational pillars are a patchwork built across millennia. But the major limitation of Celsus's 4 words is that they are just observations.
Right.
Knowing a house is on fire doesn't tell you how the fire started or what the fire department is doing or even how they plan to put it out.
So to get that mechanistic breakthrough to actually see the fire department in action, we had to wait until the invention of the microscope. Specifically, 1867 with a German physiologist named Julius Cohnheim.
Yeah, Cohnheim is an absolute legend in pathology. He took the live mesentery of a frog, which is that incredibly thin, transparent tissue that attaches the intestines to the abdominal wall, and he placed it under a microscope.
Okay.
Then he intentionally irritated the tissue, and he simply sat there and watched what happened to the blood vessels.
See, that is the ultimate scientific method. Just poke it and see what it does.
It really is. And sometimes the most profound discoveries come from simply having the patience to observe. What Cohnheim witnessed was the first half of the inflammatory mechanism. He saw the vascular choreography live.
Wow.
He watched the blood vessels dilating. He saw the rushing blood flow suddenly slow down. And he literally watched white blood cells begin to tumble along the vessel walls, eventually stick to them, and then physically squeeze out into the tissue.
He essentially watched the microscopic traffic jam form and then saw the emergency vehicles just jump the curb.
Exactly.
Yeah.
But he only saw part of the picture. He saw the cells leave the bloodstream. But it took another 15 years. So 1882 for a Russian zoologist named Elie Mechnikov to discover what those cells were actually doing once they got into the tissue.
Right. And he didn't use frogs. He used starfish.
Yes, transparent starfish larvae, to be exact.
Yeah.
Mechnikov was working in Italy, and he took some rose thorns from a garden and pushed them directly into the microscopic larvae.
That's amazing.
And he just left them overnight. When he checked his microscope the next morning, he found clusters of mobile cells swarming the thorns, actively trying to engulf and digest them.
Which he named phagocytosis.
Right.
Literally cell eating in Greek. But, I mean, introducing a massive paradigm shift like, hey, our bodies are filled with wandering thorn-eating defender cells. That must have ruffled some feathers. Did the scientific community just buy into this immediately?
Oh, absolutely not. There's
Yeah.
massive resistance. Mechnikov's cellular theory put him in direct conflict with the other heavyweight of the era, Paul Ehrlich.
Oh.
Ehrlich was championing the humoral theory. He argued that it was the chemical components floating in the blood serum, what we would eventually call antibodies in the complement system, that were the real defenders, not Mechnikov's wandering cells.
The classic scientific feud. Two brilliant minds convince the other is completely wrong.
Oh, they fought bitterly over it. But they actually ended up sharing the 1908 Nobel Prize in Physiology or Medicine.
Oh, that's hilarious.
It was an incredibly elegant resolution, really, because it turned out they were both right. Inflammation is an integrated cellular and humoral response. The serum proteins in the fluid and the mobile cells work together seamlessly.
Okay, so we know who discovered the pieces of the puzzle and how long it took. Now I want to take the listener inside their own body. Let's walk through exactly what happens step by step, seconds after they get that splinter or twist that ankle. Walk me through the actual mechanism.
Sure. So we begin with phase 1, which is the vascular phase. Within seconds of the injury, there is actually a very brief constriction of the blood vessels. But that is immediately followed by a massive vasodilation of the arterioles. The vessels just open up incredibly wide.
What triggers them to open up like that?
Chemical mediators, primarily histamine, which is released from mast cells that constantly sit in your tissue acting like sentries, along with nitric oxide. This massive widening of the vessels floods the area with blood.
Got it.
And that increased blood flow is the exact physical cause of the calor, the heat, and the rubor, the redness, that Celsus wrote about 2,000 years ago.
So the pipes are widened and more fluid is rushing in. But if the goal is to get white blood cells out of the pipes and into the tissue, the vessels have to do more than just get wider.
Right. They have to change their physical structure. The endothelial cells, the cells that line the inside of the blood vessels like tiles on a tunnel wall, actually contract.
Wait, they contract?
Yeah, they pull apart from each other, creating these microscopic gaps between the tiles. We call this increased vascular permeability.
So the pipes intentionally get leaky.
Very leaky. Protein-rich fluid from the blood starts pouring out through these newly formed gaps and pools into the surrounding tissue. This escaped fluid is called exudate.
Exudate, okay.
And as this exudate accumulates, it physically swells the tissue up like a water balloon. That's your tumor, the swelling. And because all that extra fluid drastically increases the local pressure in the tissue, and because newly released chemical mediators like bradykinin are directly irritating your raw nerve endings, you get dolor, pain.
I just love visualizing this. It's like the body is reacting to an emergency by widening a major highway to let more traffic in, but then it intentionally opens all the toll booths so the emergency vehicles can drive completely off the road and directly into the fields where the fire actually is.
That analogy sets up phase 2 perfectly. Because getting those emergency vehicles, the white blood cells off the highway and into the field, is a remarkably complex maneuver. This is the cellular phase. The primary first responders in the first 24 hours are cells called neutrophils, and the body executes a highly precise sequence to get them to the target.
So walk me through the physics of this. Because blood is rushing through these vessels incredibly fast, how does a single cell manage to stop and get out?
It starts because the vessels are dilated and leaky, which means the actual flow of the blood slows down significantly. As the current slows, the neutrophils drift from the fast-moving center of the bloodstream over to the outer edges. They start bumping against the vessel wall and rolling along it.
Like they are looking for a place to parallel park.
Exactly. And the vessel wall actually helps them. It sprouts these loose chemical tethers molecules called selectins that act a bit like microscopic Velcro.
Microscopic Velcro.
Yeah, they loosely catch the rolling neutrophils, slowing them down further.
But they need to completely stop to get out. How do they actually hit the brakes?
Well, the tissue where the injury occurred is basically screaming for help, by releasing chemical alarm bells called cytokines. These alarm bells trigger the vessel wall to deploy much firmer chemical grappling hooks. The rolling neutrophil essentially locks onto these new hooks, slams on the brakes, and grips the wall tightly.
Okay, so now the neutrophil is glued to the inside of the pipe. How does it squeeze through those microscopic gaps you mentioned earlier?
It performs a process called transmigration, or diapedesis.
Diacopedesis.
Right. The neutrophil physically morphs its shape, literally flattening itself out to squeeze between those pulled-apart endothelial cells. It exits the blood vessel entirely, guided out by specific junctional proteins acting like a doorway.
That's wild. But once it's out in the tissue, it's essentially in the dark, like it doesn't have eyes. How does it find a microscopic bacteria in a giant swollen foot?
It follows a chemical scent. This is called chemotaxis. The bacteria are leaving behind chemical breadcrumbs, or the body's own damaged tissue is releasing specific lipid mediators. Yeah, the neutrophil sniffs out this chemical gradient, moving from areas of low concentration to high concentration, marching directly to the target. And once it arrives, it executes Mechnikov's discovery phagocytosis. It engulfs the threat.
And the humoral system, the proteins Ehrlich was so obsessed with, they actually help with this part, right? They coat the bacteria to make it easier to grab.
Yes, exactly. It's a process called opsonization. The body coats the bacteria with antibodies or complement proteins. It's essentially putting handles on a slippery microscopic criminal so the neutrophil can grab it and devour it more easily.
If you want a concrete example of this entire system going into overdrive, look at acute appendicitis. What is actually happening in a ruptured appendix?
Acute appendicitis is the textbook human example of this exact mechanism. Something physically obstructs the appendix, which leads to a massive bacterial overgrowth inside the organ. That triggers this entire vascular and cellular cascade we just described. If a pathologist looks at a removed appendix under a microscope, they don't just see a swollen tube. They see massive vascular congestion, tissue flooded with exudate, and millions of neutrophils infiltrating the tissue wall trying to fight the bacteria.
Hold on, so what does this all mean? If this highly orchestrated dance, the widened vessels, the leaky pipes, the swarming neutrophils, is an incredibly precise defense system evolved over millions of years to save my life, why is my first instinct to grab an ice pack and pop an Advil the second I twist my ankle?
That's a great point.
Aren't I actively sabotaging my own emergency responders? Why are we treating something that is trying to heal us?
This raises an important question, and it leads directly into some of the most pervasive misconceptions about inflammation. Let's break them down, starting with the biggest one.
Okay.
The assumption that if it's red hot and swollen, there must be a bacterial infection in there.
Yeah, people definitely equate inflammation exclusively with infection.
And it's completely false. Inflammation can be entirely sterile. Yeah. Think of a severe sunburn. That is acute inflammation caused by UV radiation damaging your skin cells. A twisted ankle is acute inflammation caused by mechanical trauma tearing your ligaments.
Oh, right.
Even a gout attack is just the body launching this exact same vascular and cellular sequence because uric acid crystals deposited in a joint. There are absolutely zero microbes involved in any of those scenarios, yet the body still runs the exact same emergency program.
What about pus? The common thought is like, oh no, there's pus, the infection is winning, the treatment failed.
That's another major misconception. Pus is quite literally a microscopic graveyard of dead and dying neutrophils that have successfully done their job fighting the infection, mixed with some liquefied tissue debris.
So it's a good thing?
Exactly. If you see pus, it doesn't mean failure. It signals that a highly active, robust immune response has taken place.
And fever. We almost always treat a fever like a glitch. Like we view it as the body's engine overheating because it's stressed out.
Not a glitch at all. Fever is a deliberate, highly adaptive evolutionary response. Those cytokine alarm bells we mentioned earlier, they don't just act locally in the tissue. They travel through your bloodstream up to the hypothalamus in your brain, and they actively turn the dial on your body's thermostat to a higher temperature.
Wait, so the body is intentionally frying the pathogens?
Precisely. Many bacteria and viruses struggle to replicate at higher temperatures, while your own immune cells actually function more efficiently when it's a bit warmer. The body is creating a hostile environment for the invader.
Okay, so inflammation is fundamentally protective. But we have to talk about the dark side, because when this system goes wrong, it can be lethal.
It can be catastrophic. If the inflammatory response escalates uncontrollably and stops being a localized response in your foot or your appendix and instead spreads throughout your entire circulatory system, it becomes deadly.
We're talking about sepsis.
Yes, and we all just lived through a harrowing global example of this with the COVID-19 pandemic. In the most severe, life-threatening cases of COVID, what was killing patients often wasn't the virus directly destroying the lungs, it was a cytokine storm.
The alarm bells basically wouldn't stop ringing.
Right. The body's acute inflammatory response became so massive and dysregulated that the lungs filled with fluid, that exudate we talked about, causing acute respiratory distress syndrome, or ARDS.
Wow.
The systemic inflammation caused widespread organ failure.
So the emergency responders effectively blew up the city to save it from the virus.
Exactly. And that's why frontline doctors had to pivot to using powerful anti-inflammatory steroid drugs like dexamethasone to intentionally suppress that lethal immune overreaction.
It's crazy to think that we've been trying to stop this process for centuries without knowing how it works, like aspirin. Ancient Romans chewed on willow bark for pain and fever, but it wasn't until like 1971 that a pharmacologist named John Vane actually figured out the mechanics of why it works.
Yeah, what's fascinating here is that gap between knowing that something works and knowing how it works. Vane discovered that aspirin blocks a specific set of enzymes in the body called COX enzymes.
And what do those enzymes do?
They are the factories that produce prostaglandins, which are a specific type of chemical mediator that massively amplifies pain, heat, and swelling during the vascular phase.
Got it.
By blocking the factory, aspirin cuts off the supply of prostaglandins, and the inflammation is stunted. He won a Nobel Prize in 1982 for figuring out the mechanics of a remedy humans had been using for thousands of years.
That is incredible. Okay, here's where it gets really interesting. We know how the body starts the fire. We know the molecular mechanics of how the cells get to the injury. And we know how humans have historically tried to put the fire out with ice and willow bark and NSAIDs. But how is the body supposed to put the fire out on its own?
Right.
Because for most of modern medical history, the assumption was that acute inflammation just kind of, faded out, right?
Yeah, that was the accepted dogma for the entire 20th century. The prevailing theory was passive resolution. The idea was that once the bacteria are dead or the splinter is gone, the chemical alarm bells just dilute and wash away, the neutrophils die off, and the tissue quietly returns to normal. It was viewed as a fire just running out of fuel.
But that's not what happens at all.
No, it's not. In the 1990s and 2000s, a pharmacologist named Charles Sirhan radically changed our understanding. He discovered that resolution is an active biological process.
Active, okay.
The body doesn't just let the fire burn out. It runs a completely separate, highly orchestrated shutdown program. Late in the inflammatory response, the body synthesizes a completely different family of specialized lipid molecules.
Molecules with incredibly cool names, by the way. Lipoxins, resolvins, and protectins. But what are they actually doing physically?
They act as aggressive biological stop signs and cleanup crew dispatchers. They literally signal the blood vessels to stop making those chemical grappling hooks, halting any new neutrophils from entering the tissue. Then, they signal specialized cells, called macrophages, to come in and eat all the dead neutrophils and tissue debris. They physically flip the tissue's chemical switches from attack mode to rebuild and repair mode.
So acute inflammation isn't just a program with an on switch. It's a program with a dedicated molecule-driven off switch that has to be deliberately pressed.
Exactly. And if we connect this to the bigger picture, understanding that active off switch is vital. Because if that active shutdown sequence fails, if the body basically forgets to press the stop button, acute inflammation slides into chronic inflammation.
Where instead of neutrophils dominating for a few days to fix a twisted ankle, totally different immune cells like macrophages and lymphocytes set up camp in the tissue for weeks, months, or even years.
Right. And they constantly release low levels of toxic chemicals that damage the surrounding tissue, leading to scarring and fibrosis. Chronic inflammation is a massive driver of downstream disease.
Like what?
Well, going all the way back to Rudolf Virchow in 1863, he was the first to notice white blood cells infiltrating tumors under his microscope, and he hypothesized a link between chronic inflammation and cancer.
A link that is now completely validated, like chronic H. pylori infections in the stomach causing constant inflammation that eventually leads to stomach cancer.
Exactly.
But as much as we understand these pathways now, as perfectly mapped as they seem, we really have to talk about medical hubris. Just because we understand a cellular mechanism on a whiteboard doesn't mean we can safely hack it in a living, breathing human being.
That is so true. Drug development is filled with sobering cautionary tales about exactly this. In the 1990s, scientists identified that the cytokine TNF, one of those major alarm bells we discussed, was a primary driver of organ damage and sepsis.
Okay.
The mechanistic logic was flawless. If TNF causes the damage, let's invent a drug to block TNF, and we will save patients from dying of sepsis. So pharmaceutical companies ran massive clinical trials with anti-TNF drugs.
And the trials completely failed.
They largely failed to improve survival because the biology of a whole, complex patient fighting a systemic infection is infinitely messier than a single chemical pathway isolated in a petri dish. But an even more famous example of this hubris is the drug rofecoxib, better known as Vioxx.
Oh, I remember Vioxx. It was a massive blockbuster painkiller in the late 90s and early 2000s.
It was hailed as a miracle drug. It was a highly selective KOX2 inhibitor. The brilliant idea was to block the specific prostaglandin synthesis that causes pain and inflammation in your joints, while sparing a slightly different prostaglandin pathway that protects your stomach lining.
Right, because stomach irritation is the big, dangerous side effect of older NSAIDs like ibuprofen.
Exactly.
So block the pain, save the stomach. It sounds perfect. How did it go so wrong?
It was forcefully withdrawn from the global market in 2004 because it was linked to a significantly increased risk of heart attacks and strokes.
Wait, how does stopping my knee from hurting trigger a heart attack? What is the actual physical connection there?
It comes down to how interconnected the body's chemical signals are. The exact same prostaglandin pathways that drive inflammation and pain also have essential non-inflammatory jobs in the cardiovascular system.
Oh, no.
Yeah. Specifically, they maintain vascular balance by keeping your blood slightly slippery, preventing it from clotting too easily.
Oh, wow. So you take Vioxx to block the pathway causing your knee pain?
And by blocking that pathway, you accidentally turn off the signal that keeps your blood slippery. The blood gets sticky, it forms a clot, and that clot travels to the heart. The body reuses the same chemical signals for totally different jobs.
It's an incredible reminder of how beautifully complex and sometimes fragile these systems are. So what does this all mean? Let's bring this all together for you listening.
Acute inflammation is a vascular event before it is a cellular one. Celsus's famous 4 signs, the redness, the swelling, the heat, and the pain, are just the surface-level symptoms of a microscopic deep-sea dive happening under your skin, involving dilated leaky pipes, chemical grappling hooks, and swarming cells.
Beautifully said. And it doesn't always mean you have an infection, and most importantly, its resolution isn't a passive fade-out, but a highly active, molecularly driven shutdown sequence.
The main takeaway is that the next time you twist an ankle or get a sunburn or reach for an ibuprofen, you aren't just dealing with a minor annoyance. You are interacting directly with the legacy of Julius Conheim's frog tissue, Elie Metchnikoff's starfish, and thousands of years of human medical history, all playing out in a highly choreographed dance right there in your own tissue.
It definitely makes you respect a swollen ankle a lot more. But I want to leave you with a final thought to chew on. For thousands of years, from ancient Romans chewing on willow bark to us reaching for modern NSAIDs, humanity's entire medical strategy has been to block inflammation from starting, to suppress the chemical alarm bells. But if our bodies have their own built-in resolvent molecules, like a secondary program designed to actively clean up the battlefield and shut the process down naturally, what if the future of medicine isn't about stopping the body's alarm bells from ringing, but simply teaching the body how to successfully finish the job?